So that is the evaluation of the cartilage status using the Oxford classification. So 7 categories: normal, superficial damage, and partial thickness loss. And for thickness loss, localized and extended, and slight small bone defect and big bone defect. Maybe it is very similar to the ICRS classification in the normal superficial damage and the partial thickness, and for thickness and bone defect. So it's a similar. It's very macroscopic. So yesterday in the lecture, so we the speaker alerted that the lateral side, on the lateral side, cartilage wear is very posterior, unlike the medial side. The medial side is extended facet. So bone wear is called indexation. So this area of cartilage loss is here, so we can find easily. But it is quite difficult to find the lateral side because on the lateral side, the bone wear is always occur in the flexion angle. So, for example, 40, 60, or sometimes 90 degrees. So, to find lateral cartilage status, we need to flex the as much as possible. It's very important. So, as the deflection in and observed lateral cartilage in the limited field of UKA, so it is quite difficult to find articular cartilage. So MRI is beneficial. I have some worry about lateral cartilage, where some lateral cartilage damage in the preoperative weekday. So we can try hard to find such a lesion, but lateral sides are very clear in preoperative MRI. It is okay. Just look, it's okay, but some worry on the preoperative MRI. We should try to find that the lateral damage the cartilage as much as possible. Anyway, so second one is the ACL integrity. So status of ACL. So normal, in the normal is means the of course the fiber is very good and appearance is very good. And the surface of ACL is covered with the normal synovial. So we can easily find some vessels, small vessels in the synovial. So there is some small membrane along with the small vessels. So we can make sure this ACL is intact. So in the both appearance and both functional, so because there is synovial layer, or maybe blood supply or the ACL is normal. But the initial stage of ACL damage, the first of all, the cup synovial surrounding the ACL fiber can be damaged in the initial stage, mainly due to the osteophytes, maybe here, this area, lateral wall or the intercontra notch. Okay, so then at the first only the synovial is damaged, then gradually the main fiber of the ACL is damaged and worn some part of the fibers, and fiber can spread. In this area, in this category, the fiber or at once in the one string, but here we can separate easily. And in the same time, this category can include the partial here, such as, so yesterday, maybe yesterday you heard in the initially the intermediate fiber can be damaged due to the osteophyte here. So then, so fiber, it can be split, and some fiber can be worn, but it works very well. It works very well. So we can confirm hooking of this ACL and confirm the tightness and the volume of the ACL. And sometimes if you worry about the integrity of ACL, you can draw until you can try until draw or lock one this intraoperatively and make sure that are very well or not. Anyway, so these three categories, we consider these ACLs as interfunctional functioning. On the other hand, that is a fragmented. The fiber exists, but very fragile and easy to break. Or sometimes in hooking, it can be torn easily. There exists the ACL fiber, but it doesn't work anymore. And the last one, absent. So sometimes it is very difficult to identify the longitudinal split and fragmented. So carefully looking and the hooking and how the stress is very important. So how to do if we find this appearance in the relatively, we always should prepare some optional operation for such reason. To predict this ACL damage, we can use preoperative MRI. That might be beneficial. So we don't need to give up UKA. So based on the preoperative MRI finding, just prepare the backup TK or sometimes backup lateral UKA. And absent, one out. Maybe they see the contraindication of the TKA and contraindication of UKA in most cases. Anyway, so considering the both cartilage status and ACL integrity, ACL function as deficient. So, furthermore, we should consider friction contracture and the limited of friction. But basically, unlike fixed bearing UKA, so friction contracture and friction loss are not contraindication. So in most cases, so we can find the second cause of limitation of extension of friction. The main cause is also found here and here. So on the lateral X-ray, you should find the osteophyte in the anterior part on the tibial train, tibial plateau, and posterior to the posterior condyle. So that implies they make the limitation of friction or extension. So if now please imagine if we remove these osteophytes, the patient can extend more and the patient can flex more. So that might not be a contraindication of UKA. So most in most paper, especially in the fixed bearing field, so more than 15 degrees of extension loss is a contraindication. Of course, such patients, such patient group includes the more severe osteoarthritis, is no ACL and lateral side damaged, the severe bone loss on the medial side, and also that cause the flexion and extension limitation. But lateral side is very clear, and it implies an impact ACL, but only the osteophyte here. And in the same time, we don't mind the osteophyte here until the flange and until superior inferior or patella. I never mind. And in the same time, I never remove the osteophyte there. Because that can cause some inflammation or bleeding. So I believe the osteophyte removal here and here unnecessary. So important is remove the osteophyte anterior, just anterior to the ACL insertion and posterior and intercontract, especially the lateral side. That this osteophyte is very sharp, like knife, so that can cut where abrade the ACL. So to prevent the future ACL deficiency, so you should remove 3 osteophytes here, and intercontract. So, okay, so that is principle of mobile bearings. So osteophyte removal is very important because if there is some osteophytes that can push MCL or other ligaments, that can underestimate the gap. So before the gap balancing, all osteophytes, especially in the median border or the medial femoral condyle, should be removed completely. Then adjust the flexion and extension. Then we go to the next step. So first of all, so remove osteophyte is very, very important. Then we can move on to the next step to gap adjust. OK。あまりにも基礎的なことなんですけども、割と言われてます。で、よく屈曲拘縮15度以上ダメよと、論文見てもよく書いてるんですけども、必ずしもそうやね。この屈曲を取ったら絶対伸びるっていう分かるの。そんなも別に角度気にしなくていいし、オックスフォードの時にはあんまり気にしないです。もう他のところでするし、で、逆にオックスフォードの他の基準を満たしてたら、こんなにひどい症例っていうのはあんまりないです。こういう症例っていうのもほとんど TK の範囲になっちゃうので、はい。あんまり気にしたくてもいいけども、手術中にはしっかりと取ることが必要ですよと、ことになります。はい、以上です。